Now I invite Dr. NIMMY RAJ for the talk on precision diagnosis, advanced tool for ocular surface disease.
A very good morning to one and all. Now coming on to precision diagnosing dry eye precisely. What is the need? Are we diagnosing it correctly or just randomly telling the patient you are having dry eye, you take this lubricant, go home, you will be all right. So what is the need for a standard approach to diagnose dry eye? In order to have a uniformity among practitioners, for the patient to carry a valid report suggesting that he or she has a documented dry eye, and also to reassure the patient that the symptom that he or she is having is actually due to some underlying disease. There is this and this abnormality in your parameters, that is why you are having these symptoms, and we have treatment options for this. Clearly explaining to the patient that your symptoms are actual and we have a particular disease named this and the underlying factor is this. For that, there is a need for precisely diagnosing the disease. And also, secondarily, any disease needs to be precisely diagnosed to actually come to the conclusion of how much is the prevalence, how much is the incidence rising, what all care needs to be taken from the government side, what all research is needed further. So, for all these purposes, precisely diagnosing dry eye is very important. Now, the diagnostic algorithm for dry eye was given by Deuce Stu in 2017. And in that, a systematic approach to how to approach a dry eye patient was given. First of all, a questionnaire has to be taken and then diagnostic tests were told, then classified into evaporative or aqueous deficiency and then manage accordingly. Now, recently, the Deuce 3 diagnostic methodology was proposed and they were analyzing, is there anything to be changed in the previous methodology? Are we going in the right direction in the previous, what all were told in the previous methodology? And also we needed to redefine, if at all needed, the previous definition of dry eye. So they found that there was no need to mainly change the dry eye definition. It was already told as multifactorial disease, and also the pathology was in loss of homeostasis of the ocular environment. And also specifically they have added the term that there is loss of homeostasis of the tear film as well as the ocular surface. That is the only change that has been made in the definition. And another major approach they have brought about is a new etiological driver based approach. So what is the etiology for dry eye? They are subclassified it now not only into aqueous and evaporative. Whatever is the etiology, you take care of that etiology, manage that etiology so that the patient improves. And also they have given guidelines on possible future research or whatever is needed. So the diagnostic criteria is that in a symptomatic patient, that is if the screening questionnaire is showing that the patient is actually having symptoms, the cutoff given is more than 4 points if the patient is getting on the OSDI 6 questionnaire. Previously, they had asked to use 2 questionnaires like OSDI 12 and DEQ 5. Now they are telling just minimize the number of questions and lower the burden on the patient so that patient can also give you a good response. So the OSDI 6 questionnaire is proposed and the cutoff score is 4. There is no such thing as mild, moderate, severe according to the questionnaire now. Previously, there was with the OSDI 12 questionnaire. And the tear filling markers, they want one of either of these 3 to be positive to be diagnosed as a dry eye disease. So symptoms should be there. One of the 3 tests, that is tear filling markers, non-invasive tear breakup time of less than 10 seconds. In those places where there is availability to assess the tear breakup time non-invasively, that is the test that has been proposed. The value is less than 10 seconds. Then osmolarity, whenever you are able to assess the osmolarity, the machines need to be there. The values given are uniocularly or difference between the 2 eyes. Then the other diagnostic criteria is ocular surface staining. You have to stain cornea. Not only the corneal staining has to be checked, conjunctival and lid margin staining is equally important. Moreover, the cornea will show staining later on only. The lid margin and conjunctiva may be showing staining characters earlier. But the stain that is being used is Lissamine or Rose Bengal. The availability of stain also matters. So this is the questionnaire. I think we all can read it up later. The main thing is you have to analyze these things and give a value according to a 1 month experience. Previous 1 month, are you having these symptoms? Earlier on, the OSDI had it previous 1 week. Now they are assessing over a month. Tear breakup time is interval between a blink and the first appearance of discontinuity. It is a Placido disc-based technology is being used. The test, when it is done objectively, there is a universal mapping of the ocular surface. So we will know which all areas is actually having an instability in tear film. Temperature, humidity, air circulation will definitely affect the test values. There are so many machines available nowadays. IDRA, Tear Check Plus, Keratograph 5M are few of the options. Then when you don't have access, the algorithm from DUCE 2 also give you the option of fluorescent breakup time, but the value is less than 5 seconds. But instilling fluorescent itself will cause damage to the tear film stability, and that is the limitation. And it may not be an actual reflection also of the, and highly subjective. My tear breakup time may not be the tear breakup time for another practitioner. And osmolarity testing, most important is interocular difference. And many studies have shown that if there is an increase in osmolarity, those patients when undergoing a cataract surgery or refractive surgery might have more symptoms after the procedure. The limitations are osmolarity testing is not available everywhere. Location, according to from where you are taking the value, it might change. It's not a repeatable procedure according to the current instruments available. Staining is the strongest sign and which all of us can obviously do in our clinics. It indicates loss of surface homeostasis. Also, cornea with conjunctiva and lid staining is important. There are many grading systems available, whichever we can use. We can use the algorithm given by DUCE have used the SICA staining score for cornea and core grade for lid. It's an image showing corneal staining, conjunctival staining and lid margin staining. There are studies which show that staining is the main indicator of dry eye disease, omitting the other two like non-invasive tear breakup time, or even if you don't do osmolarity, the sensitivity or prevalent sensitivity doesn't decrease much. And DUCE 3 tells you that in a patient who has symptoms and signs, and in a patient who has symptom but no sign, in a patient who doesn't have symptom but sign, what all is to be taken or looked into. So if the patient is symptomatic, but when you examine there is no sign, in those patients will be having symptoms and no signs, then it can be neuropathic. There is an increased sensitivity to pain in that patient, or it is a transient discomfort. For the past 1 week, patient has been using screen too much or sleep is disturbed. So there is no sign as such, but the patient is symptomatic. But if the patient doesn't have symptom and when you examine, you are seeing signs, that means that patient is going to become symptomatic if at all you do a surgery or anything, or the patient might be diabetic having lesser sensation in the cornea, or neuropathic causes may be there underlying. If both symptoms and signs are present, you diagnose it as dry eye disease, but you have to have an etiology driven approach in which you have to assess where the tear film deficiency is in the lipid, aqueous, mucin layer, or is the blink of the patient, blinking rate is abnormal, or there is any pathology in the lid margin, any neural dysfunction. Or any neural dysfunction or inflammation is going on. So there is no much time to go into everything. Now I'll come to the tools that are available, recent tools. There are many machines available. The most advanced or the most popular ones are the Ocular Keratograph, LipiView, IDRA, Ocular Surface Analyzer. So IDRA is the name of the instrument. It is not an acronym. It will give you lipid layer thickness, tear meniscus height, NIBUT, and also infrared meibography. So you can eventually get all details from a single report itself and diagnose the patient as having lipid layer deficiency or aqueous layer deficiency, or is the blink of the patient abnormal or meibomian gland as such is less in that patient. Lipid view will give you an idea about the lipid layer deficiency, how much is the quality, quantity, what is the blinking rate, complete blink, partial blink. Also, the machine gives you a C factor in which it gives that the patient whether the test was reliable or not. There is another machine that is ocular surface analyzer. It integrates the question. Everything is assessed according to the methodology. DEQ questionnaire is integrated and tear meniscus height, LLT, TNI beauty, mibography, everything is assessed together. Another machine is ocular keratograph. It is an advanced topographer that will also give you almost all these values, TMH, mibography, hyperemia score, everything. Other few machines are also available. So whatever is that, if you don't have any access to the machine, still you can effectively diagnose dry eye disease by taking a proper, asking the proper questions, getting symptoms if the patient is actually having symptoms, and always lubricants can be started. There is a need for etiology driven approach that is the best that is being proposed now. There is the need for a standardized, reproducible, repeatable dry eye protocol which needs to be given in the future. Thank you.